Hi, I'm Dr. Mila Brujic, and welcome to the OI show, where we're going to be talking to Dr. Jeff Sonsino about being down with OCT. Dr. Sonsino, how are you, young man?
How's it
Please,
going?
great, great. Give everybody a little bit of an introduction on yourself, where you practice, what your passions are.
Sure. I'm in group practice in Nashville, Tennessee, right in kind of the midpoint of town. I got to Nashville because my first job out of residency in cornea and contact lens was at Vanderbilt University Medical Center.
It's awesome.
And there I was charged with building the region's largest complex contact lens practice. And so it took me about 5 years to do it, and we did it. We started a dedicated scleral lens practice back in 2006. In 2015, I realized that my wife in private practice had a much better life than I did. And I was just going to join her and settle into a nice Main Street optometry practice. And that's not at all what happened, because as soon as I left Vanderbilt, about 85% of my patients, my complex contact lens patients, followed me. About 10% more trickled in over the next few years. But as soon as the community ophthalmologists and optometrists heard that I was doing it out in private practice, they all started sending. And so for the past about 5 years, I've had a complex contact lens only private practice, meaning I do not see patients who do not have corneal pathology. In fact, Neil, this is funny. You'll appreciate this. This was the first time ever this past week I declined seeing two A-list country music stars. I passed
Wow.
those on to my wife because I figured with general eye care, she would better serve them.
Jeff, so this is awesome. This is very, very cool. And this could be a whole other topic on specializing in optometry, but Jeff, you've built up quite an impressive specialty lens practice. And that's what I want to do a little bit more of a deeper dive into with you, because you've literally leveraged the power of anterior segment OCT technology. I remember 15 years ago when we got our first OCT, I predicted that I was going to use it about 80% for glaucoma, about 20% for macular degeneration. And then I remember asking the rep, what am I going to do with this? Like, what's this nozzle that you like attach to the front of it? And he said, well, that's your anterior segment module. And I asked him, I said, well, what am I going to use this for? He said, well, some people take pachymetry scans, some people are taking angles. I said, oh, okay. So I kind of didn't know. And today it's helping you refine how you care for scleral lens fits. And you fast forward even me today, my ratios are totally flipped. About 50% of the scans are anterior segment, about 35% are macula, about 10 to 15% are glaucoma. So it's totally flipped on what I thought. But Jeff, I want to do a deep dive with you and anterior segment OCT. And what are you really leveraging on that anterior segment OCT to help redefine and with precision fit these lenses on patients?
Well, I think you just said the magic word. It's precision, right? There's simply no better way to evaluate vaulting scleral lenses on the eye than with anterior segment OCT. It's critical hardware that you need to have if you're fitting these patients. If you go on Facebook, you hear a bunch of stories from people that say, oh, I'm evaluating my scleral lenses with, the slit beam estimation technique, or just using a slit lamp. And those are the exact patients that I see in my practice that I am fixing some of the most horrific scleral lens fits that are out there today. The enemy of the scleral lens patient is the doctor that thinks they know how to evaluate scleral lenses with the slit beam estimation technique. And I can't mince words, and I can't say it any more direct than to say that you should not be fitting scleral lenses at all unless you are using anterior segment OCT. I think your question, Neil, was, what specifically am I doing with anterior segment OCT to arrive at that precision? And there's two main things that you're looking for when you're fitting scleral lenses, and that is to make sure that you're vaulting the apex of a cone in keratoconus or the center of the lens in any other diagnosis. Obviously, if somebody has some corneal scar from acanthamoeba or something, you absolutely do not want that scleral lens pushing on that scar. That is something that we believe will hasten scar formation. And so looking at your central vaults is very critical. But
Jeff,
then also,
if I was to ask you, like, give me your ideal vault over the cone or over the surface of the cornea, when you're fitting the patient, what's that ideal number for you, or is there an ideal number for you, or does it depend?
well, you don't have to ask me what mine is. I'll tell you what is in the literature for the ideal vault, because Longy Mashad and his group figured this out back in 2012. And basically, he published a series of 2 papers where they looked at like how much oxygen goes through a scleral lens material, goes through the post-lens tear reservoir and actually gets to the cornea. And the recommendations that the Mashad group gave in the first paper was that you really have to be at 200 microns of vault in order to get optimal oxygen back to the cornea. Now, the 2 other things that you have to do to satisfy getting the most oxygen to the cornea that you can is you have to have a lens material that lets through enough oxygen. And so the recommendation of this paper was to fit using materials with the highest dk over T. And then the other part of that is the T portion in dk over T. You have to look for a lens that you can minimize the central thickness on. And by doing those 3 things, you're getting most of the oxygen to the cornea. But then he followed that paper up with another paper that said, okay, let's look at the difference between a lens that has 200 microns of vault versus one that has 400 microns of vault. And the difference was, if you go from 200 to 400 microns of vault, you're restricting 30% of the oxygen getting to the cornea. And when you hear that, you're like, oh my God. What that means is it demands that you have precision in your scleral lens fits.
Yeah.
Because, if you're restricting 30%,
you don't want the variability of the estimation through the slit lamp, which is why you're looking at those precision-based numbers when you're fitting these patients.
Exactly.
So Jeff, there's a lot of conversation around corneal clearance and clearing the cornea at the apex. Do you leverage your OCT technology to actually look at limbal clearance as well too? And if so, how do you look at that, and how do you know what's acceptable when it comes to looking at the OCT?
So that is the second thing that we use OCT for. After we realize that we have enough central clearance, is we're looking to make sure that we are clearing the limbus. In the beginning, when we were talking about cleaning up some bad fits, that's the majority of where I see bad fits, is when practitioners are not looking at the limbus and they're smashing the limbus. When you smash the limbus, you're providing mechanical insult to the limbal stem cells. And when you're providing mechanical insult to the limbal stem cells, we know that this is a situation that can create limbal stem cell insufficiency. And you'll get away with it for the first year, maybe 2 years, maybe 3 years, maybe 5 years. But if that scleral lens patient is wearing that lens for a decade, 2 decades, and you're smashing the limbus, you are at some point going to create limbal stem cell insufficiency. And so we're always looking to make sure that our lenses land outside of the limbus. And I could tell by the way you asked that question, Neil, you were hedging a little bit. The question really now is, where is the limbus? And the answer to that is no one actually knows, including ocular pathologists. There's no defined borders of the limbus. We just have to make sure that we're falling outside of the periphery of the cornea and giving a little bit of a fudge factor on the outside.
It is amazing, Jeff, when you look at the OCT scans in that region, you gain a greater appreciation of the fact that the conjunctiva and the corneal epithelium are continuous. You can see definitive changes when you're looking directly over the cornea and directly over the conjunctiva, but in that transition zone, you see that there is this shifting, and to be able to, like you said, directly identify this is the edge is almost impossible unless you take cellular samples, which we're probably not going to be doing in clinical practice. Saying that though, Jeff, what about the landing zone? Because I know that a lot of times this will dictate success versus failure, in particular when we're talking about post-lens tear fogging. Are you leveraging the OCT for this as well too? And if so, how are you doing that?
In the same images that we take to look at limbal clearance, we're also imaging the haptic and how it's aligned with the sclera. And so we take our images in at least 4 quadrants. And when I say at least, I mean if the principal meridians of that lens, meaning, everyone should be fitting toric haptics at this point. We know for fact that about 95% of eyes out there have a toric sclera. And so to try to match that shape, we should be fitting toric haptics. What we're looking for is the principal meridians of that lens. So when my techs put a scleral lens on an eye, they take them right to the slit lamp and they're looking for the orientation markers and where those orientation markers sit. And what we try to do when we're taking OCT images is we take each of those quadrants. So we're taking 4 images around the periphery of the lens and at the haptic, and we're lining those up with the principal meridians of the lens. And so if the principal meridians of the lens are here and here, we take 4 OCTs of the periphery. We take one here, one here, one here, and one here. If the principal meridians of that lens are, at an oblique axis, then what we do is we take 4 OCTs at horizontal and vertical, and then we also take 4 more at the principal meridians. And the reason we do that is because we know that the shape of the cornea is not a circular shape. The cornea is an ovoid shape, and the ovoid is largest, it's widest at the horizontal meridian.
Yep.
So we want to know at the widest point of the cornea how close we are to the limbus.
And Jeff, when you're looking at those scans and assessing the landing zone, what are you simply looking for in that landing zone, the foot, so to speak, to have an even displacement along the conjunctiva and underlying sclera that's sitting? Or are there any other kind of clinical pearls you could share about the OCT assessment in that region or area?
There are so many things you can learn about not only the fit of a scleral lens, but also the behavior of the patient. Okay. Now, it depends what designs you're using. Everyone should be using at least 2 designs of scleral lenses that aren't similar, right? So for example, one of the designs that I use as my principal lens that we fit, that the landing zone or the haptic is curved, okay? And that curved landing zone allows for kind of a lot of slop in the system where if it's not perfectly aligned, it's a curve. So the curve will actually take up the misalignment just fine. There are other designs that we use that have a flat landing zone, okay? And in those lenses, we need to make sure that that flat landing zone is exactly parallel with the sclera in each meridian, okay? So in other words, we don't want a lens that lands with toe down or heel down on the sclera. But the clinical pearl that I'll tell you, Emil, is you can tell a lot about behavior of the patient by looking with OCT at the haptics. And I announced this from the stage at GSLS, and I thought everyone was doing this, but apparently there weren't many people that were doing this. When we teach our patients to insert lenses, the way that we teach them to insert a lens is by using the most gentle technique they possibly can. So what we tell our patients is, you take your fingers, open your eyelids, bring the lens onto the surface of the eye, just kiss it. And before you move this hand, let go of your eyelids. Your eyelids will grab that lens and pull it onto the eye, rather than you having to push it onto the eye so hard to get it to stay. When patients are forcefully inserting lenses, you squeeze out a bunch of fluid in the post-lens tear reservoir and you create suction, you create a vacuum. And what that will do is it will suck the lens onto the eye. And when you look at OCT, you can actually see an indentation into the sclera if the patient is inserting their lenses too hard. When we see that, we correct the behavior, and then it corrects a bunch of problems like redness after the patient removes their lenses, difficulty removing the lenses. And it's something simple that you can see on OCT that you can change the behavior of and immediately get an improvement in function.
Jeff, this was awesome. Absolutely fantastic advice, and truly leveraging the power of that anterior segment OCT again 15 years ago, and we didn't know what we'd be using it for. It sounds like you really have a great process in your practice. Jeff, thank you so much for being a guest on our show. We truly appreciate it.
A lot of fun, Neil. Thanks for asking.
And thank you all for joining us on this episode of the OI Show, where we were down with OCT.